We are live now. Good evening, esteemed and all the delegates. Thank you for joining. This is Sahiti on behalf of Sheer Connect, welcoming you all for today's webinar, episode 33 of Amogs, Emergency Obstetrics Committee with Mogs. And the topic is Management of Pregnancy-Induced Hypertension. So it's my privilege to introduce the convener of today's webinar, Dr. Monica ma'am. Ma'am is
let it be. I and Dr. Madan are the coordinators for the program. Dr. Sujata Dalvi madam is the convener for the program. I take privilege to introduce her as well. Can we have Dr. Sujata's slide, please? Dr. Sujata Dalvi madam is a consultant obstetrician and gynecologist from Mumbai. She's an honorary clinical associate at Naurozji Wadia Hospital. She is the treasurer of Mumbai OBGY Society and an associate editor of Jogi. She is also the president of Mumbai Menopause Society and immediate past secretary of Amogs. We welcome you, ma'am, and thank you for being the convener of this series. We now welcome you all to the 33rd episode of our webinar series conducted by the Amogs Emergency Obstetric Committee with the Mumbai OBGY Society. And we are delighted to have to join us today for an insightful session on emergency obstetric and preeclampsia. This initiative is the brainchild of Dr. Sneha Buyar Madam, the esteemed chairperson of Emergency Obstetric Committee, whose vision and dedication have made this webinar series possible for us. We look forward for an engaging and informative session. And as we move forward, please join us for the ceremonial lamp lighting ceremony, symbolizing the illumination of knowledge and start of our inspiring event. Thank you, Sahiti. It is my great pleasure to introduce Dr. Sneha Buyar Madam, a distinguished obstetrician and gynecologist with accomplishments spanning an impressive array of awards.
Yeah, Monica.
Yes,
we can skip that. We can skip that.
Sure, over to you, ma'am, for the further proceedings.
A very good evening to one and all, respected seniors and dear friends. I'm very happy to welcome all of you. My respect and regards to all the seniors here. I'm thankful to Madam Suvarna Kadilkar, Dr. Geeta Balsarkar, and Madam Sujata Dalvi for this collaboration. And I take this opportunity to thank and welcome all of you, all the respected dignitaries, especially Dr. Jaideep Tank, the president of FOXI, respected Sir Dr. P.K. Shah, the past president of FOXI. And of course, I'm so fortunate to have so many past president of FOXI today on board, blessing us. Dr. Rishikesh Pai, Madam Nandita Parsidka, both past presidents of FOXI, and of course we have the illustrious chairpersons, the faculties, and all the panelists as well, all over Mumbai society, I would say. I welcome all of you, and without much ado, I would just take this opportunity to thank Madam Suvarna Kadilkar, first of all, for having this program and collaboration. So I would request Madam you to speak few words first, and then I would invite the chief guest for today's program.
Okay, thank you, Sneha, for this wonderful webinar that you have organized on your committee on obstetric emergency of Amogs. I hope I am audible. Yeah. So, Sneha, you are doing a wonderful job for towards this committee, and very good program that we have curated on Amogs platform. I can see Dr. Monica and Dr. Madan are doing a great job for this webinar since long. And so many dignitaries have already joined. Dr. P.K. Shah, sir, I can see Dr. Rishikesh Pai, Dr. Nandita, Dr. Rajendra Sarogi, Dr. Asha Dalal, and so many others have joined. And I sincerely thank all of you for being here at this webinar on obstetric emergencies. Sneha, as you know, I've just landed in Delhi, so I won't be able to talk, and I have to actually actually get off the flight. So please continue. I'll be joining in between, and I can come back for the panel when the panel discussion happens. And wish you all the best. I'm sure the webinar is going to going to be very enlightening with the presence of all the dignitaries there. Thank you so much.
Thank you so much, madam. Thank you so much. In spite of your busy schedule and the travel, you tried to join, and thank you so much for your precious words. So thank you so much, all the dignitaries. Once again, Dr. Rishikesh Pai, Nandita Madam, Asha Dalal, and Madam Madhuri Patel. I would like to have all of your blessings one by one, and of course, your words of guidance. So I invite Dr. P.K. Shah, sir, for his precious words of guidance and blessings. I'm sure Mumbai society, or not Mumbai society, the entire India will not need your CV, sir. Such an illustrious personality and a highly decorated CV. Of course, my mentor, Dr. P.K. Shah, sir, past president of Foxy, and we would love to listen to your precious words, sir. So over to you.
Thank you very much for your kind words, Sneha. And before it becomes dark and you don't see me anymore in the car, I think I'll finish my talk. It's a fantastic program, star-studded and power-packed program. There's not so many VIPs in one webinar. All the office bearers of Mogs, Dr. Kiran Kurtukoti, Dr. Rajendra Singh Pardesi, Dr. Madhuri, and obviously you, the chair of committee, and Amogs official, Dr. Suvarna, Dr. Geeta Balsarkar, Dr. Sujata, all these people are there. Like Jaideep Tang, Dr. Rishikesh Pai, Dr. Nandita, Dr. Madhuri Patel, and Dr. Asha Dalal. Again, the PIH is something very practical from the obstetric practice point of view. So you have been picking up fantastic topics, and it's so nice to be with you in any webinar. And I wish you all the very best for your future endeavor. And we want hardworking person like you in Foxy. And I wish you success in your vice president's post from West Zone for the election year 2024. Sujata Dalvi is going to speak on prevention, prediction of preeclampsia. Rajendra Sarogi, Niranjan Chavan are going to chair that. And then you have Madhuri Mendali who is going to talk on management of eclampsia. And again, Dr. Kunjal and Dr. Gandhali are going to chair that. And that is followed by panel discussion, which is going to be conducted by you as moderator. And we have many luminaries as panelists. So I wish you all the very best. And thank you very much for making me a part of this webinar. And I'm sure not only this webinar, but all the activities that you will do in future will be a grand success. Thank you very much and all the best again.
Thank you so much, sir. Thank you for your precious words and your blessings as well.
Sorry, I want to add Monica's name because I just met her at Udgir few days back. And Monica Umbadand is doing very good job from a small place. And I wish her also all the very best. Thank you.
Thank you, sir. Because respected President Foxy, Dr. is traveling and we are missing him. We would like to go ahead with the precious words from Dr. Rishikesh Pai, sir. So, Saiti, can we have sir CV?
Yeah, no need to. Thanks a lot for inviting me.
Yes, Saiti, please, the most popular personality and the president of Foxy, sir.
Thank you, Sneha. First of all the best for your ventures, and we hope that you succeed in your ventures. And I would like to first of all acknowledge Dr. P.K. Shah, Dr. Nandita Palsetkar, Dr. Asha Dalal, Dr. Madhuri Patel, Dr. Sarogi, who is our great surgeon, and Dr. Suvarna Khadilkar, our Foxy president, Madan, who is now a dynamic person, is slowly becoming bigger and bigger. And becoming more active. And as I said, Dr. PK said, Monica Oberban, who has done a lot of fantastic work. I can see her all the time being very active in everything that she's doing, and wish you all the very best. And also a lot of other people are there. I can't take all their names, but they are all in my heart. So wish you the very best for everything. PIC is a very important topic, and I'm sure that today you will have a lot of enlightenment about the topic, and you will that will help the people in implementing it in their practice and trying to reduce the morbidity and mortality because of it. I don't want to take much of your time. Wish you the very best.
So thank you so
What do
much
you, I
for
forgot
your
to say
support
that
and
yes,
blessing.
we are all waiting for you, all of you, to come to the All India. Dr. Nandita is there, the chair, and all of the seniors are there, all of from Mumbai, and all of us are waiting to take care of you, do your khatardari for the AICOG. Thank you.
Thank you so much, sir. Thank you so much for the invitation. And I too urge that all of us should get registered for this AICOG Mumbai, and we are looking forward to it, sir. Thank you so much once again. Now it's time to listen to the Queen, Dr. Nandita Parshid.
Thank you.
Madam, most popular
Thank you.
Amogs at Fox SR, and of course, a lovely person. Over to you for your precious words, madam.
Thank you, Sneha. Sneha, you've been so hardworking and so amazing. And I think you've really spread knowledge in Foxy. So, all the best. May you do well. I would like to actually begin by acknowledging my mentor in Amogs, Dr. Asha Dalal. She's the one who took me into Amogs under her wing and really trained me in Amogs. So, thank you very much. And of course, there is Dr. PK Shah, there's Rishikesh Pai, there's Dr. Saragi, I can see him, and Madhuri is there. And I really want to compliment Madan and Monica. Just now, Monica called up. I said, Monica, I'm not there. But she's so sincere and, in calling you up and telling you, I think it's amazing. So, I think all the best. I don't want to take too much time. The only thing that I feel that the prevention of PIH and management, that is something that's important, which people need to know how to pick up, what are the tests. In fact, there are some genetic polymorphisms also, which actually guide you towards PIH, which can happen early or late. So I think all those things need to be discussed, and people need to be aware of what are the latest technologies, precision medicine, the different biomarkers and all, and the new tests like the exosomes and all, which are available today for the diagnosis and prevention of PIH. I think it's very important topic you've taken. So all the best, and I'm sure all the speakers will do a great justice. And Mogs, of course, is Suvarna, who's been there as a Mogs president. So I'm happy that Mogs is tying up with Amogs for this very, very important topic. Thank you. Thank you very much.
Thank you, madam. Thank you so much for all your appreciation and support. Thank you so much for your precious words as well. It's my pride and privilege to invite Madam Asha Dalal, such a generous, loving and caring person. I would say, Madam, I can't thank you enough for all your support and your blessings. Madam is such a illustrious personality with highly decorated CV, and she's the mentor in the Department of Obsgyny, Sir H.N. Reliance Foundation Hospital Research Center, Professor and Head Department of Obsgyny at TN Medical College and B.Y. Nair Charitable Hospital, Mumbai, and of course, she was the president of Amogs and, of course, trustee of Amogs. And we are very eager to listen to your precious words, madam. Over to you, Madam Asha Dalal, for your words of wisdom and guidance.
Sneha, you know that you always have all my blessings. What I really appreciate about you is you take care of the small things, the little details which make a difference. Big things don't matter in life. All your topics are very well chosen, and Madan and Monica, great job you all are doing. I agree wholeheartedly with Nandita that now is not the time only to discuss about it, but to see that these preventive measures reach to everybody. It's not enough that in cities we are able to access things which tell us that this person is at risk for preeclampsia, but we should be able to offer this to everybody. I once again congratulate you, wish you all the best for all your efforts, and thank you very much for making me a part of this. Thank you.
Thank you so much, madam. I think we don't see Dr. Madhuri Patel.
Ma'am, she's trying to log in, but she's not possible, ma'am. She will join in some time.
So whenever she joins, yeah, we will have her word later on. So I just thank all the dignitaries once again, especially Dr. P.K. Shah sir, Dr. Jaideep Tang, though we are missing him, Rishikesh Pai sir, Madam Nandita Palshidkar, Dr. Asha Dalal madam, and of course Dr. Madhuri Patel madam. I thank all the chairpersons, such a revered teacher, Rajendra Saragi sir, Dr. Niranjan Chavan, and of course, Dr. Kunjal Bhatija and Dr. Gandali, Dr. Suvarna Khadilkar, Madam Secretary, Dr. Geeta Balsarkar, and Dr. Sujata Darvi, Madam, who has convened this program so wonderfully, and Dr. Monica and Dr. Madan being the coordinator for this program. I thank all the panelists as well, and I welcome them. Dr. Geeta Balsarkar, Dr. Shailesh Kore, Dr. Priya Vora, Dr. Ashok Anand, Dr. Niranjan Maidev, Dr. Rahul Maikar, Dr. Payal Lakhani, and of course, I welcome all of you once again, and I thank everybody for gracing the program and of course actually participating here. So without much ado, we should start with the academic session, and over to you, Dr. Madan and Monica, for the same.
Thank you, Sneha ma'am, for allowing us.
Dr. Madhuri, just a moment. Dr. Madhuri Mehndare, who is the speaker for today's program, we welcome Dr.
Thank you, Sneha ma'am, for giving me and Madan an opportunity to coordinate such a prestigious webinar. I would thank all the stalwarts of Mogs for gracing the occasion, including PK sir, Pai sir, Nandita madam, and Suvarna Khadilkar madam, Saroghi sir, for gracing this occasion and blessing us with their words of wisdom. I request Dr. Madan to please continue with the scientific session.
Thank you all the dignitaries once again. Let us move on to the proper scientific sessions. I think Dr. Sujata ma'am has not joined.
So we take the second session first.
Yeah, we will start with the session number 2, which is on the management of eclampsia. And the eminent speaker we have got is Dr. Madhuri Mehndare madam. And the chairpersons for this session are Dr. Kunjal Bhatija and Gandhali Devrukkar. Yes, may I introduce Dr. Gandhali ma'am. She is a consultant OBGYN and head coordinator of maternity and child care department of Okad Hospital, which is attached to SRCC Hospital. She is interested in high-risk pregnancies and presented many papers. Yes, Dr. Kunjal ma'am is a consultant obstetrician gynecologist at Bombay Hospital and Medical Research Center. She is assistant professor in OBGYN and experience of more than 18 years. And she has participated as chairperson and judges at various conferences. I welcome both the chairpersons, and over to you to start the session. And please introduce Dr. Madhuri ma'am. Over to you. You are muted, ma'am.
Please unmute, ma'am.
Please unmute.
Can you hear me now? Am I audible?
Yes, ma'am.
Yes.
Yes.
Okay, all right. So thank you, Dr. Madan, for that kind introduction. My greetings to all my teachers and mentors. And with their blessings, we move on and practice every day. Preeclampsia is a very, very big part of routine OBGYN practice. And Dr. Mehndare is very is going to enlighten us about the topic today. Along with this, Dr. Mahendra, I would just like you to focus upon the latest markers of preeclampsia and how we can prevent it. I mean, everyone knows how to treat preeclampsia by now, but the thing is how to prevent it, how to take care of it is what we need to see. So over to you, Dr. Mahendra. She's a OBGYN consultant and a professor at LTM Science. She's treasurer Amogs, managing council member, MOGS for the past 11 years. And she has a lot of teaching experience and she has won a lot of awards, including Durusha Best Committee Member Award, Wonder Foxy Award, Pramila Bhatia Young Scientist Award, and she has co-authored 2 Foxy textbooks on high-risk pregnancy. So she's the right candidate to enlighten us about preeclampsia today. Over to you, Dr. Madhuri.
Thank you, ma'am, for those kind words. Please allow me to share my screen.
Yes, ma'am. Now you can share the screen.
Can you see my screen?
Yes, we can, Dr. Madhuri.
Yeah.
Yes. Yes. My full screen.
So ideally, I was the second person to talk today, and that's why my topic was management of eclampsia. Prediction and prevention of preeclampsia is something which Sujata madam is going to cover. But in my talk, I have made it a point that I also cover that how we predict eclampsia and how we can deal with cases where the situation may not arise, and if it arises, how do we optimize it? So we all know that eclampsia is the occurrence of new onset generalized tonic-clonic seizures and coma with preeclampsia. So looking at the incidence, it's about 2 to 3% with severe features of preeclampsia who have not received any prophylaxis, any maxillary prophylaxis in this group with severe preeclampsia. About 0.6% of women with preeclampsia without severe features, 1.5 to 10 cases per 10,000 deliveries in developed countries. But in a country like ours, the incidence is as high as 6 to 157 cases per 10,000 deliveries. Being at a tertiary institute, we have definitely seen a change from this scenario now. With increasing awareness, increasing markers, we have seen a decline in the number of eclampsias, except in cases where the follow-up has not been very good from the patient side. The various risk factors that we have seen are genetic, about 37% seen in personal or family history. Endothelial dysfunctions, which could be resultant because of renal diseases, diabetes, a PCOD case, dyslipidemias, thrombophilias, infections, immune-mediated and angiogenic mechanisms in nulliparas, primiparas, twin gestations, molar pregnancies. The main pathophysiology, as we all know, is basically hindrance in the cerebral blood flow regulation. So we know that it could be because of cytotoxic edema or the vasogenic edema which is causing this. Coming to biomarkers. So serum uric acid level above 5.2 is a good marker of oxidative stress, tissue injury, and renal dysfunction. Ratio of the soluble FMS like tyrosine kinase 1 and placental growth factor, which is more than 85, has 86% positive predictive value for severe preeclampsia to eclampsia, and the decrease in the vascular endothelial growth factors. We have papers supporting the same, wherein association of uric acid with progression of preeclampsia and development of adverse conditions were more common in those where the uric acid was on the higher side. Similarly, for the other growth factors and soluble FMS was seen. The premonitory symptoms that present can be hypertension, headache, visual disturbances of different types like scotomata, loss of vision, blurred vision, double vision, visual field effects, and photophobia. Right upper quadrant pain or epigastric pain. However, in 25% of patients, there would be no symptoms and patient would still end up having eclampsia. Now, we have seen varied presentations. What scares the most is the injury after that. A patient presenting with tonic-clonic seizures, having tongue bite, having a lot of frothy, bloody sputum, post-ictal confusion, drowsiness, and sometimes might have neurological deficits post that, and presenting with fetal bradycardia at the same time. In antenatal cases, between 20 to 30 weeks, the incidence seen is around 20%. In between 30 to 37 weeks is around 40%. intrapartum about 20%, and postpartum about 21%. Well, we know that with more and more information about eclampsia, the actual eclampsia incidence is on decrease. And unless proven otherwise, and convulsion in pregnancy is considered to be eclampsia, but we must consider the other differential diagnosis also. Sometimes we have seen one case in last 2 years wherein it was a brain mets from invasive molar pregnancy that presented with amenorrhea, UPT positive, and a convulsion. Persistent neurological deficit, which could where a patient presents with convulsion and there's a stroke-like sign. There are intracranial hemorrhage. There could be encephalopathies, tuberculoma, neurocystocercosis, metabolic abnormalities like hypocalcemia, hyponatremia, hypoglycemia, and sometimes it could be a part of patient presenting as HUS or thrombocytopenic purpura or any kind of head trauma. Coming to my main topic for today, which is managing these cases. So the key principles while managing these cases is preventing maternal hypoxia, any kind of trauma once she's convulsing, treatment of severe hypertension that she presents with, preventing any further seizures, and thinking about the prompt delivery, which is the basic definitive management. The first thing that comes to your mind when you see a eclampsia patient is calling for help, preventing injury at that time, giving a lateral decubitus to the patient, thinking that the aspiration should be avoided, immediately giving her oxygen, checking for her oxygen saturation. Only subsequently do we think about administering magnesium sulfate, because most eclamptic scissors are self-limited. However, magnesium sulfate is not mainly because to arrest that particular scissor, but to prevent any further scissors that can come in this patient. So immediate left lateral position with propped up, oxygen by mask at 6 liters, putting a mouth gag immediately, having a bed which has rails, patient to be restrained. It is possible that the patient is in post-ictal phase and agitated, and vital monitoring. At this time, if the patient also presents with severe hypertension, it is very, very important to get her blood pressure down. Now, the objective of treating the severe hypertension is basically to prevent any kind of acute incidents like myocardial ischemia, a hemorrhagic stroke, or ischemia, or a failure, or any kind of acute renal insult at this particular time. This antihypertensive treatment should be initiated as quickly as possible. If the systolic pressure of 160 and a diastolic pressure of more than 110 or both is seen and is confirmed as persistent, that is, it stays so for 15 minutes or more, and immediate treatment is required. The available literature that is there says that it is very, very important at this time to get the blood pressure down within 30 minutes to 1 hour and get it to about 149. Now, the various antihypertensive agents that are available to us are IV labetalol, hydralazine, nifedipine in the oral form, and also there are papers which speak about nitroglycerin drips in these patients. The most common what we use in our hospital is, and we have the maximum experience with, is IV labetalol. We do not have that much of experience with hydralazine. However, in an ICU setup with good monitoring, hydralazine also has a very good effect. So labetalol, about 10 to 20 milligrams IV, you make it, and every 10 minutes you keep repeating the BP, and once the BP has not come down, you give about, and you go on escalating these doses. You can go up till about 300 milligrams cumulative dose, or even keep the patient on a continuous infusion if needed. What we have to remember is that tachycardia is lesser common when it comes to labetalol. If the patient is a case of myocardial disease, decompensated cardiac function, a known case of asthma, heart block, or already has bradycardia, labetalol should not be given, and we should resort to another drug. So hydralazine is 5 milligram IV or IM, then about 5 to 10 milligrams IV every 20 to 40 minutes to a maximum dose of 20 milligrams. A higher or a frequent dosage, if of hydralazine used, can give a little bit of hypotension, headache, and somewhat affect the fetal heart tracing too. Nifedipine in the sustained release can be given 10 to 20 milligrams orally if the patient is completely conscious, and it can be repeated every 20 minutes and thereafter every 2 to 6 hours, wherein the maximum dose can be 180 milligrams. So there are papers about nitroglycerin infusion versus hydralazine infusion in acute management of patients, which land up in such scenarios. It could be in cases of severe preeclampsia or an eclampsia presenting with such high BPs. Now talking about how do we prevent the further scissors that can come in this patient. Cochrane review says that mainly the data coming from developing countries indicate that a significant reduction in recurrent scissors and eclampsia-related mortality was seen with the use of magnesium sulfate. Now, magnesium sulfate administered intramuscularly or intravenously has been seen superior to phenytoin, diazepam, or the Lytic cocktail that was being used, and it is associated with less maternal and neonatal morbidity. There is no role for mannitol in the routine care of women with eclampsia. Now, the ways of giving magnesium sulfate are different regimens can be followed. Now, the IV infusion regimen, wherein 4 to 6 grams loading dose diluted in 100 ml of fluid is given. Now, in the market, we already get a ready preparation of 4 grams, which is given over the period of 15 minutes and then followed with continuous IV infusion of about 1 to 2 grams per hour. This should be discontinued only 24 hours after delivery or the last scissor, whichever is longer. The intramuscular dosage is wherein the 4 grams as 20% solution is given IV, which the rate should not be exceeding 1 gram per minute, and immediately by magnesium sulfate, 50%, 5 grams given in both buttocks, and then 5 grams in alternate buttocks every 4 hours. For recurrent convulsions, in spite of giving the regimen, if convulsions are seen after 15 minutes, up to 2 grams more IV as a 20% solution can be given, not to exceed about 1 gram per minute. And if the woman is of a higher weightage, then an additional 2 gram can be given slowly. It's very important that every time that you are administering a dose of magnesium sulfate, the patient's urine output, her knee-jerk reflexes, her respiratory rate is seen, because various stages of toxicity can cause these changes. And if one comes across loss of reflex, one has to wait till the reflexes come back to administer further doses of magnesium sulfate. If the urine output is less than 100 ml in last 4 hours, there are no other signs of magnesium toxicity. Reduce the next intramuscular dose to 2.5 grams or the IV infusion to 0.5 grams per hour. It is very important to also send magnesium levels at this time to see what is the level in the blood at that particular time. Patellar reflexes if depressed and if respiration is normal, just withhold the further doses until the reflexes have returned back, and at the same time ask for a magnesium level. Respiratory depression, stop magnesium, give oxygen by mask, and administer calcium gluconate 10 ml of 10% solution over the next 10 minutes. One has to think about delivering this patient, as the definitive management of eclampsia is prompt delivery. Induction is reasonable for pregnancies about 32 weeks or more with a favorable Bishop score, which is more often seen in patients who have landed up with eclampsia. Long induction should be avoided and a clear endpoint for delivery planned within 24 hours. Induction is not advisable in women who are less than 32 to 34 weeks of gestation with an unfavorable cervix. So when it comes to route of delivery, there's this study which dealt with route of delivery affecting maternal and perinatal outcome in women with eclampsia. And what they did was, it was a trial that was randomly done in 200 rural Indian women at more than 34 weeks with eclampsia. And then what was compared was cesarean delivery or induction after initial stabilization. Planned cesarean delivery did not significantly reduce the rate of adverse maternal or fetal outcomes, and almost 3/4 of women in the planned vaginal group did successfully deliver vaginally. Now, about intrapartum fetal monitoring, one has to remember that during eclamptic scissors, there are usually prolonged fetal heart rate decelerations, even certain amount of fetal bradycardia, and sometimes an increase in the uterine contractility or the basal tone can be seen. After a scissor, because of the maternal hypoxia, hypercarbia, the fetal heart rate tracing may show recurrent decelerations, tachycardia, and reduced variability. However, once the maternal hemodynamic stabilization is done, one has to look for the tracing. If any persistent of abnormal fetal tracing, the delivery immediate delivery has to be planned. The various complications that we have to think about while managing these patients are abruption, which is seen about 7 to 10%, patient going into DIC in about 7 to 11%, complications like pulmonary edema, acute renal failure, aspiration pneumonia, cardiopulmonary arrest have to be kept in your mind. Liver hematoma, about 1% have been seen, HELP syndrome in about 10 to 15%, perinatal death is seen in a higher number, about 5.6 to 11.8, and preterm birth in almost 50% of these cases. Now, going further, there is this study which was published about incidence, risk factors, and associated complications of eclampsia. It was a population-based cohort study from Canada, about 1,481 cases, and a case mortality rate of 0.34% was seen. Severe morbidity, including acute renal failure, assisted ventilation, embolism, shock, and ARDS was seen. Is neuroimaging required in all cases of eclampsia? Now, eclampsia patients who normally would not show an expected response to the treatment should be screened by neuroimaging like CT scan or MRI to exclude serious other morbid CNS pathological conditions. Neuroimaging has found various CNS abnormalities like venous infarct, venous sinuses, and infectious tuberculosis or neurosis. We also are able to diagnose cases of press in these patients with the help of imaging. Be presenting like headaches, altered mental status, having seizures. They might not have visual losses. White matter vasogenic edema, which predominantly affects the posterior occipital and parietal lobe of the brain. Now, how should these patients be managed? Like any other seizures, they have to be on magnesium therapy. Any fluctuation in the blood pressure has to be well maintained. Electrolyte balance and magnesium levels have to be checked. These patients have to be managed in an intensive care setup. Corticosteroids and mannitol should theoretically reduce the edema. However, there is very less data. And there was a time when we would routinely give all our press patients corticosteroids and mannitol. But as per the newer studies, we have started at Sion Hospital, we've started managing these patients conservatively. Also, what we have now practically seen is a lot of patients who are exposed to imaging in absence of any kind of these symptoms. Conservatively over the period of time and not discharged to see better recovery. So the preeclampsia, vigilance for severe features of preeclampsia, weekly routine investigations to rule out any HELP, evaluated by seniors, counseling patients and relatives together about importance of home BP monitoring, educating patient about the premonitory symptoms is very, very important. So what we realized is when it comes to prevention, in cases of preeclampsia with severe symptoms, prophylactic MAC-Self has played a very, very important role. Whereas in preeclampsia without these severe symptoms, magnesium sulfate has not really been very effective in preventing eclampsias. So if you would say like a load, what they would say is you would have to treat about 139 preeclampsia patients to prevent one eclampsia if we were to give magnesium sulfate in patients of preeclampsia without any severe symptoms. But the same number reduces to about 60 cases if we are to give magnesium sulfate in preeclampsia with severe features. Recurrence rate and later life sequelae. Recurrent eclampsia occurs in about 2% of subsequent pregnancies. The risk appears to be reduced by close maternal monitoring and timely interventions. In 2011, the American Heart Association added preeclampsia as a major risk factor for development of cardiovascular diseases too. Preeclampsia associated with IUGR and eclampsia and recurrent eclampsia is most strongly associated with cardiovascular sequelae later in life. So what is atypical preeclampsia and eclampsia? Atypical preeclampsia and eclampsia is when we do not see it accompanied with proteinuria, but hypertension is there, or there would be no proteinuria, just an elevated blood pressure. Atypical can also be a convulsion just presenting with HELP, presentations before 20 weeks or more than 48 hours postpartum, or a patient who on giving MAC-Self is showing resistance to MAC-Self. One very important topic that I wanted to cover today was about transporting these cases of eclampsia. We as a tertiary institute many a times receive patients of eclampsia from real far away. Transfer of the complicated pregnant patients to a facility with appropriate medical, surgical, obstetric, or pediatric resources can reduce the morbidity and mortality. The most common reason for these transfers usually is the neonatal care because of extreme prematurity. Severe preeclampsia and eclampsia should be managed at a tertiary institute. While these transport, it's really very important to remember about recording, documenting, communicating prior to transport. See that during transport, she is well attended and the stability of the patient during this transport is with a very good healthcare service three-tier system. And in Mumbai, there is a proper referral system that is followed with pre-referral communication with the Maharashtra government's emergency medical services and the availability of 108 ambulance. The mortality of eclampsia has severely reduced, and we've been able to manage these patients really well. It's very important that before transfer, one has to assess the maternal symptoms of headache, epigastric pain, and deep tendon reflexes are seen. Vital signs are well seen. At least in cases of preeclampsia with severe symptoms, a loading dose of magnesium sulfate should be administered prior to the transfer of the patient. The required doses of antihypertensive medication should be given. A catheter should be put in, and a fluid administration with an oxygen support should always be given to the patient during the mode of transport. As I conclude that eclampsia is a very conclusive and convulsive phase of a wide spectrum disease. It's more conclusive. RCTs are required to see the efficacy of biomarkers that we spoke about in predicting eclampsia. Key management, like we already discussed, is to look that there should be no trauma, no hypoxia, manage the BP, prevent the recurrent scissors, and prompt delivery. Scissors resistant to magnesium sulfate should be evaluated with imaging, and other differential diagnosis should always be kept in mind. Eclampsia can be avoided by vigilant management of preeclampsia and a good patient counseling. While transporting cases of eclampsia, good communication, good documentation, a good transport team, good transport personnel to take this for the appropriate transport of this patient, and a rapid mode of transport is very, very important. With that, I conclude my talk, and I would like to thank Amogs and the team today for giving me this opportunity.
Thank you, Dr. Madhuri. That was extremely comprehensive and a very, very well presented topic. I think everyone knows how to treat preeclampsia, but this was a very quick revision and a very good revision at that. And I'm glad you touched upon the mode of transport as a tertiary care center where I have worked in Wadia, and it brought me back memories as a tertiary care center wherein we used to also receive a lot of bad eclampsia patients from all over. And there was no catheter, there was no even IV line access taken for that matter. And I used to wonder why would they transfer patients like that? So I think you a very good point about transferring of patients that you have touched upon. I'm glad you did that.
And Dr. Madhuri, the presentation was excellent. Most important thing, we have to give a brief history before transferring the patient, that what time dose you have given, about what time she convulsed, and all the details has to be given before transferring the patient. And the lecture contained every important minute details of management of eclampsia. Thank you very much.
Any questions from any panelists? Anyone?
Yeah, what is more important, when I was a resident, we used to have a dark room. I don't know what that system is still there at Sahan or no. But we used to have an eclampsia rooms, isolated room. Nobody is allowed to enter inside. I don't know. Madhuri will be able to tell whether still that dark room exists at Sahan or it doesn't exist. I'm talking about way back in 77.
Madhuri, they're asking you whether the dark room still exists or no in Sahan Hospital.
Yes, ma'am.
They're asking you whether dark room for an eclamptic patient, does it still exist in Sion Hospital in labor room?
No, sir. We do not have. We do
Yeah,
not.
yeah, same here.
Have
Even in Vadia, we don't have any now dark rooms for
Yeah.
eclamptic patients.
I think maybe 3 decades ago, when we were the PG students also, we had the dark room, quiet and totally dark. But nowadays, the concept of well-equipped room has come up. So I
Correct,
think
yes.
because that was in fact isolated, but much neglected room, I would say. Apart from the
we prefer the patient right in front of us with all the monitors attached and absolute
obstetric, maybe in obstetric SDU
in HDU types, you know, in the labor room. Yeah.
When I was head of the department at Cooper and KEM, that time I had made it a rule. I used to tell all my residents that make it a point for the doctor to accompany the patient, and all the doctors used to accompany the patient. Why? Because no bad word were spoken about the doctor. Otherwise, generally the tendency of the RMO is to tell बहुत लेट लेके आया, मर जाता था, ऐसा होता था, वैसा होता था. So to avoid all that, I had made it a rule. I had given 500 rupees to all my residents that please offer him a glass of water, if possible a cup of tea. The advantage was we used to extract all possible history from the doctor, and doctor was not scared to come. See, basically doctor is scared to accompany the patient. So that system, I got rid of all that stupid things from Cooper Hospital when I was HOD at Cooper. So if you can implement that, nothing like it. You know, doctor should not be scared to accompany the patient.
No, I think, sir, that doesn't happen now. And also, like you said, sir, if a doctor accompanies, it shows a lot of compassion as a profession, lot of care from our side. Certain things are not in our hand. But as sir said, I completely agree. The ease of communication and management goes to another level when you meet the previous doctor.
Just one more thing, Dr. Madhuri.
Yes,
I
think nowadays the concept has come that even the medical officer at the primary health center, not even that, but even the nursing staff, you know, they should be trained for giving magnesium sulfate and the primary care for eclampsia, that at least the loading dose should be given to this woman before referring to the next center. So I think nowadays the blame game shouldn't happen. I think the doctor is worried about that. So that should not happen. Thank you so much.
It's not happening nowadays. You know, everybody is giving max self and then shifting the patient. So it's not happening.
The incidence of eclampsia by itself has definitely gone down.
Yes.
Definitely gone down. Thank you. Thank you.
Shall we move on?
Yes, definitely.
Thank you, Dr. Madhuri ma'am, for your excellent presentation, and thank you both the chairpersons for chairing the session. We are moving on to the session 1, which was shifted to session 2. For that, we have got the eminent speaker, Dr. Sujata Dalvi ma'am, and the chairpersons, respected Dr. Rajendra Sarogi sir and Niranjan sir. I think Niranjan Chauhan sir has not joined. Sarogi sir is Emirate Professor, SET GS Medical College and KEM Hospital, Mumbai, ex-honorary and HOD, RN Cooper Hospital, Mumbai. He is a senior consultant, Nanavati Hospital, Mumbai.
Madan, it's all right. Don't
welcome. Yes, sir. Welcome, sir. Niranjan sir, I think he has not joined yet, child. He's the professor and unit head at Sion Hospital, joint treasurer, past Foxy, and president Amog, past president Amogs. Welcome both the chairperson, and I hand over the session to respected Rajendra sir. Please take over. Thank you.
Thanks a lot. First and foremost, I would like to thank Amogs, all the office bearers, Mogs office bearers and Foxy office bearers for inviting me. Special thanks to Dr. Sneha Bhuyar for considering me eligible to become a chairperson for this session. We have Dr. Sujata Dalvi.
You don't have to introduce
all possible hospitals on city side. What's more important, she is a future president of Mogs. She is associate editor of Joggi.
That's fine. That's fine.
I welcome you, Sujata, and your talk will be on prevention and prediction of pre-eclampsia.
Yes. Yeah. I'll just share my slides. I mean, share the screen. Yeah, sorry.
Before you go to that, Sujata,
Yeah,
I'll tell you why it's important to know about PIH and preeclampsia and eclampsia. Because in olden days, our idea was to prevent eclampsia so that preeclampsia can be treated.
correct.
Came the era of preeclampsia. We want to prevent preeclampsia so that PIH can be treated. And now the time has come to prevent even PIH. The reason behind it is preeclampsia, there is twofold increase in risk of stillbirth, 35% higher risk of stillbirth, 80-fold increased risk of iatrogenic preterm delivery less than 33 weeks, 40-fold increased risk between 33 to 36 weeks of iatrogenic preterm delivery, 4-fold increase in low birth weight rates, 2-fold higher neonatal mortality, and increased risk of low Apgar score, febrile seizures, encephalopathy, and neonatal intensive care unit admission. With that, I hand over the mic to Dr. Sujata Dalvi.
Thank you, Dr. Sarogi. It's my privilege that I got a chance to be introduced by Dr. Sarogi as such. But before I start, I would like to express my gratitude to convener of today's program, Dr. Sneha Buyar, who is also an Amogs Obstetric Emergency Committee chairperson. And Amogs is headed by our very vibrant president, Dr. Kiran Kurtakoti. I would like to wish Sneha for a future endeavor in Foxy. And I would also like to express my gratitude to our MOGS president, Dr. Suvarna Khadilkar, for giving us an opportunity to have this program. My today's topic, Dr. Sarogi already elaborated on why we want to predict and prevent preeclampsia, but let us just get into a little bit of details, and then he will give us the consensus report on the same. So if you go to see pregnancy-induced hypertension, it's a leading cause of maternal and perinatal mortality as well as morbidity. It is predominantly because of impaired placentation. That's a theory which everybody knows, and that's the reason it leads to preeclampsia or maybe pregnancy-induced hypertension. There are two types: early onset, which requires delivery before 34 weeks, and we do have late onset preeclampsia, which will require delivery on or after 34 weeks. The early onset preeclampsia has more adverse outcome as compared to the late onset preeclampsia. Major challenge would be an early identification of a high-risk pregnancy who are likely to develop early onset pregnancy-induced hypertension, so that one can take necessary measures maybe to improve the placentation and to reduce the prevalence of PIH. If you go to see how do we screen these patients, the first and foremost, we should start from the maternal history. In case you need to go into the details, and detailed history is of an immense importance, that is previous history of preeclampsia, previous early onset preeclampsia, previous preterm delivery less than 34 weeks, preeclampsia in more than one prior pregnancy, patient of a CKD, chronic hypertension, type 1, type 2 diabetes, autoimmune disease like an SLE or an APLA, or a patient who has got a thrombophilia. Then also you need to figure out whether it's a first pregnancy, that is primary, more than 10 years of a pregnancy interval between the two pregnancies, age of maternal age more than 40 years, family history of preeclampsia, reproductive technology, because we have found more increase in the incidence with an ART pregnancy happened because of an ART, excessive weight gain during pregnancy, obese patient who has gotten GTN, and patient who has got a multiple pregnancy. So this is mainly on the history part of the maternal history. Then going to the risk factors, if you go to see National Institute of Health, they have also combined with the same thing, that high risk factors, either it could be a hypertensive disease during a previous pregnancy, CKD, autoimmune disorders, I've already said type 1, type 2 diabetes, chronic hypertension, and with moderate risk factors, more than one could be a first pregnancy, age more than 40 years, pregnancy interval of more than 10 years, BMI of 35 means obese patient, family history of preeclampsia, and a multiple pregnancy. This is the same thing which has been shown into the chart. Of course, this chart has been prepared by an international standard, so that's the reason they've written patients of an racial origin that are Caucasian. They have found a less incidence as compared to Afro-Caribbean and South Asian. The incidence is little more as compared to the rest. Rest of the points are the same. What we have designed is what we call it as an HTP gestosis score. And this score has been designed by taking into consideration the careful history and assessment of the same patient at a regular interval, If total score is equal to or more than 3, then this patient is likely to be having a preeclampsia later on in the pregnancy. And mind you, this assessment has to be done at regular intervals, not only at the first visit as such. So if you go into the details of gestosis score, maternal age more than 35 years, maternal age less than 19 years, maternal anemia, obesity, that is BMI, this is according to Indian standards, so more than 30, primi gravida, short exposure of cohabitation, means a patient who has got married and then she is conceived very soon, born as patient herself is born as in small for gestational age babies, family history of cardiovascular disease, patient who has got PCOS, inter-pregnancy interval of more than 7 years, ART conception, mean arterial pressure of more than 85 millimeters of mercury, chronic vascular disease, especially dyslipidemia, and excessive weight during pregnancy. All these have been given gestosis score of 1, whereas maternal hypothyroidism, family history of preeclampsia, GDM, obesity, BMI more than 35, multifetal pregnancy, and hypertensive disorder in previous pregnancy have been given gestosis score of 2, and pre-gestational diabetes mellitus, chronic hypertension, mental patient who is having mental disorders, inherited or an acquired thrombophilia, maternal CKD, autoimmune disorders like SLE or APLA, and pregnancy, which is mainly an ART pregnancy with a donor or a surrogacy. These have been given gestosis score of 3, and we need to reevaluate the patient at a regular interval to figure out whether this patient will develop or will have preeclampsia later on as the pregnancy advances. So this is on the history point of view. Now we have something known as a screening, that is biophysical markers. So in biophysical markers, before we go into the biophysical markers, we need to know what exactly happens to the uterine artery during pregnancy. The spiral arteries, invasion of trophoblasts, vessels of a greater diameter, and it shows low resistance but very high compliance. If there is an impaired placental perfusion, it is reflected as an increased uterine artery, PI, and it is associated with an pregnancy-induced hypertension. If uterine artery pulsatility index is more than 2.5, then this patient is likely to develop PIH later on in the pregnancy. We also need to keep a tab on exactly the blood pressure. That is, mercury sphygmomanometer is basically a gold standard. And there is a little concern on the clinical performance of how you take the blood pressure. Cuff size should be proper. Deflation of the cuff size has to be made. Inter-arm difference has to be maintained, and arm position is of an immense importance, and posture of the patient whenever you're taking blood pressure is of immense importance. Automated BP monitor, though it is simple, standard, and repeated measurements can be taken, you need to have a proper cuff size and proper position of the patient whenever you're measuring the blood pressure. So whenever you're measuring the blood pressure, it's a mean arterial pressure, which is of an immense importance. So BP has to be taken in a sitting position with a back supported and legs uncrossed. Legs have to be a little bit straight. 2 measurements from each arm. Ideally, it should be taken simultaneously, with the arms should be at the level of the heart, and average of 4 measurements has to be taken before you take into consideration the mean arterial pressure. If you find the increased mean arterial pressure between 11 to 14 weeks, this patient is likely to develop a pregnancy-induced, or what we call it as a preeclampsia. Mean arterial pressure is you get diastolic pressure per 1/3 of minus systolic minus diastolic, and between 70 to 100 we take it as normal. Anything which is more than 100 is taken as on higher side, but from our side anything more than 85, anything less than 70 is taken as low. And you take into consideration the uterine artery pulsatility index plus increased mean arterial pressure. If you combine the two, it's a better predictor of preeclampsia later on in the pregnancy. Increase in the blood pressure, even otherwise in the women destined to have a preeclampsia, can be observed occasionally in the first or the second trimester of pregnancy. So whenever a patient comes for a follow-up, it's very important to take a proper BP measurement. And in case you find a little bit on the higher side, you can allow the patient to rest for about half an hour and take a repeat measurement of BP before you label the patient having a high blood pressure. Then coming to the screening, so far as the biochemical markers are concerned, these are the 2 markers. One is a PAP-A, where syncytial trophoblast-derived metalloproteinase. It increases the function of insulin-like growth factors, which it interferes with placental growth and development. So if you find low levels, then you find it is associated increase in the incidence of preeclampsia. Same thing with placental growth factor, which is a glycosylated glycoprotein, which is a member of VEGF. And if placental growth factor is synthesized by cytotrophoblast, which has a vascular and angiogenetic function, and P is associated with reduced production of placental growth factor. So if you have PAPA levels a little on the lower side, same with placental growth factor, then this patient is likely to develop a preeclampsia later on in the pregnancy. So maternal serum PAPA and placental growth factors are two biochemical markers which have been investigated very extensively, and it shows a promising result in early prediction of a preeclampsia. Preeclampsia is associated with reduced placental production of placental growth factors, and several studies have reported that during the clinical phase of a preeclampsia, maternal serum levels of placental growth factor concentration is reduced. So reduced level of placental growth factor generally precedes the clinical onset of disease. So it is very important to get the measurement or biochemical markers. So we have something known as a bias-based method, whereby which you get an information or you take into consideration the maternal characteristics, that's a history. Then you take into consideration the uterine artery pulsatility index, mean arterial pressure of the patient, and maternal serum protein associated plasma protein, that is PAPA, placental growth factors between 11 to 14 weeks, and then by which you identify high proportion of the pregnancies, and these are the pregnancies who are risk of developing early onset PIH. So Bayes' theorem says that if you consider the maternal characteristics history and combine the two biophysical and two biochemical markers, accuracy of predicting pregnancy preeclampsia is approximately 93%. So that's quite accurate. Only thing, you need to have an opportunity of monitoring the patient vigilantly, so that in case you feel that this patient belongs to this particular group, you need to be very proactive so far as her pregnancy and vigilance is concerned. You need to give a potential benefit for the same, and timely therapeutic intervention is necessary for these patients. The prediction of preeclampsia, the combination of maternal demographic characteristics, including medical and obstetric history, uterine artery pulsatility index between 11 to 14 weeks, mean arterial pressure of the patient, and maternal serum pregnancy-associated protein plasma A, that is PAPA, and placental growth factor between 11 to 13 weeks of gestation can identify high proportion of pregnancies who are at high risk of an early onset preeclampsia. So this is the same Bayes theorem. If you go to see the last one, that you take into consideration MAP, then uterine artery pulsatility index, PAPA, and placental growth factor, the prediction of patient developing preeclampsia later on, that is less than 34 weeks, is almost about 93%. So one has to be a little more vigilant so far as monitoring these patients are concerned. So predictability, the same thing, that is you take into consideration in the first trimester, whereby which the feto-placental unit is taken as a one endocrine pathology, and thereby which you feel that because of a decreased PAPA, they are bound to have some sort of a preeclampsia later on in the life, increased PI uterine artery more than 2.5, and decreased placental growth factor either in the first or the second trimester. There is a high predictability that this patient may develop preeclampsia later on in the life. In the second, later on in the pregnancy, in the second trimester, if you find an unexplained increased AFP, these are the quadruple markers. Nowadays, we don't do it. But in case you feel the need to do it, increase AFP, increase HCG and activin level, and increase inhibin A levels in the second trimester. Plus, if you have done a color Doppler, and if you find either unilateral or bilateral notching, or even if there's no notching, but if there's increased resistance index, then there is likelihood that this patient may develop preeclampsia later on during pregnancy. There are some newer markers which are under study. So I just wanted to mention that. That is in the second trimester, if you have elevated placental growth factors, these are the soluble FMS like tyrosine kinase or placental growth factors. They are under study. Maybe after a few years from now, we will be able to use these factors also. Plus, they are also plasminogen activator inhibitor 1 and 2 are also under study to figure out whether this patient is likely to develop preeclampsia later on in life. Maybe after a few years of now, we might be able to make use of these newer markers to predict preeclampsia. Now, late onset preeclampsia also poses a significant challenge especially in effective early screening. There are two stage strategies. First, in the first trimester between 11 to 13 weeks, and second in the third trimester, that is between 30 to 33 weeks, which is aimed at effective prediction requiring delivery at or after 34 weeks. You need to closely monitor these patients to improve the perinatal outcome. You need to administer hypertensive medication thoroughly, and maybe in case early delivery is necessary, then we need to do that also under a proper, in a tertiary care center where you have a good NICU facilities and where a steroid dose for early neonatal pulmonary maturity and steroids have been given to the patient. Third trimester, PI and mean arterial pressure is also of an importance to detect preeclampsia, and this can be done when you get a sonography done at around 32 to 34 weeks of gestation. Now, whenever you find any of these factors, what do? We give a prophylactic use of low-dose aspirin. Meta-analysis has proved that if you give low-dose aspirin, there's a reduction by almost about 50% with the usage of low-dose aspirin right from the time it is detected, that is from 16 weeks onwards or even earlier than that, whenever you get it detected. And the dose which is used is 150 milligrams daily. These are the few recommendations that have also been suggested along with low dose aspirin. So they have found out that in case dietary calcium intake is low, you need to give extra supplementation of calcium, that is at the dose of 1.5 to 2 grams of elemental calcium, and you get a better result. Low dose aspirin, I've already said, and aspirin 75 milligrams is, previously we used to use 75 milligrams, but nowadays they suggest 150 milligrams. So we have switched over to 150 milligrams, which gives a better results. Then, of course, there are other things which are recommended. That is, these patients should have a complete bed rest. So bed rest at home is not recommended. Even strict bed rest, even if you have detected that this patient is likely or she is high risk, strict bed rest is not advisable. Even rest at home is also not that much recommended. There should be no restriction in the diet, especially the salt intake. Though they have found it to some extent it is useful, but it is not absolutely mandatory that the salt intake restriction has to be there. Vitamin D supplementation also has not been found to be that much responsible for giving a proper outcome so far as in these high-risk patients are concerned. An individual or combined vitamin C or vitamin E supplementation have been found, though it has not been recommended, but it has been found to give a better results as compared to the rest of the supplementation. Now, this was a new test which was introduced in 2019, sometime in the month of March, by a pharma company known as a Lumila test, but somehow it didn't get picked up, and so far it has not come in the market. They were to have this test to come into the market about 5 or 6 months from then. That was in 2019. This is a detection of glycosylated fibronectin, which is a biomarker where sensitivity and specificity is more than 90%. It was generally recommended at the gestational age anywhere from 13 to 37 weeks. So that was a very wide range. If it was a negative test, one rules out PE even in a high-risk cases. So if you have a negative test, this patient is unlikely to develop preeclampsia. But if you have a positive test, then the predictive value was almost about 98%, and the validity of this test for almost about 4 weeks. So you can repeat it even after 4 weeks. So Lumila test was superior to finding out placental growth factors and also soluble fraction of tyrosine kinase like inhibitors, and validity was for about 4 weeks as against 1 week so far as the other growth factors were concerned. And it was a simple test by finger prick blood sample test, and we had the test strips which were there, and you could get result in about 10 minutes. So you need not have even a medical personnel, even a healthcare worker could do this test, and it can be repeated, and it was valid even for twin gestation, but somehow it has not come up as yet. Now, third trimester risk management is also important to detect a late onset preeclampsia, that is after about 34 weeks of gestation. That is to improve the perinatal outcome. Patient needs to be continued on antihypertensive therapy and steroids, especially for lung maturity. Early intervention, if necessary, needs to be done to reduce the complication. And as what I said, delivery should be done in a tertiary care center with a good NICU facilities. So to conclude, effective screening for early onset of preeclampsia is achieved in the first trimester, and detection rate is almost about 95% with a false positive about 10%. Maternal characteristics, mind you, history is very important, combined with biophysical, that is how you take the blood pressure, and then biochemical markers to assess the risk. Low dose aspirin is found to be effective prophylactic intervention, and you could repeat a similar test at around 30 to 33 weeks for an effective prediction of PIH even in the third trimester, but this is under evaluation. And by predicting this, we would always improve the perinatal outcome and reduce the maternal morbidity. Thank you so much.
Thank you, Sujata. It was an excellent talk. I would like to mention to the August audience that this gastosis score was developed in India itself. That's a beauty. And it has published in Jogi in 2022. So I want you to go through that gastosis score. That is one part. Second part, you mentioned about use of aspirin. Now I was going through the literature about use of aspirin. Now ACOG has told that you should use 81 milligram of aspirin. NICE guidelines say that you should use 75 to 150 milligram. ISSHP suggests that you should use 75 to 162 milligram. And FIGO suggests that you should use 150 milligram. So I really don't know what is the correct figure, but I was going through that 81 milligram thing and I came across a nice chapter on 81 milligram, how they came to the idea of 81 milligram. Actually, why they thought of 81 milligram, they found that 80 milligram is ineffective and 82 milligram is deadly. That is what they thought initially, and it was based on the principle of grains. It was found to be optimal because of grains. You know, what they found in grains was that the standard adult aspirin dose was 5 grains. And each, in metric calculation, it comes to 324 milligram. And if you calculate 1/4 of that, it comes to about 81 milligram. That is how they came to the conclusion that 81 milligram is the dose of choice. I really don't know what is the correct dose because I have gone through so many literatures and everywhere it's varying from 75 to 150. So we really don't know. It's up to the August audience to decide whatever dose they want to use. Thank you. Lovely talk, Sujata. Very nice talk.
Thank you, doctor.
Any question from the audience, please? Anything on the chat box? Nothing.
No, sir.
Thanks a lot.
Yes.
So, Sujata ma'am, what is what is the status of SFLT and PLGF? Whether you can send the test and you can get the results at once?
PLGF, no, we can't send both those tests. We can't send it. It's not done routinely. This was just from the, I would put it as, something research which they are doing it. And as of now, we are not getting it.
I could meet some of the people, they were talking about prediction. They say that, they are getting it done for some of the labs. That's the reason I asked you. I think Mumbai has...
No, at least not that I know of that we are getting it done out here, unless somebody is doing some research on that, then maybe they might be getting it done, but otherwise routinely outside.
Geeta, welcome, Dr. Geeta. I can see Geeta.
Geeta wants to say something.
Madam, I am getting it done from ICMR.
That is
Madam,
what.
She is getting it done from ICMR because it's a research project. If you send them to an outside lab, they don't do it for us.
But it really corroborates.
Yes.
But it really corroborates.
Because theoretically, I'm also convinced to it, but then I thought maybe you people are the ones who are privileged, getting that.
No, but she's saying ICMR, it's a research thing. So that's the reason those people do it. Otherwise, outside any lab you send it, they are not doing it as of now. They'll start soon. Because once it is, they are saying it is corroborated, they'll start soon, So we'll get an opportunity to send these patients for the same.
Because the presentation I had, that also said that if you are doing it serially, then that definitely gives you enough prediction that
Definitely. Actually, that Lumela test was very good. You know, it was that Bharat Serum and Vaccine had come out with it in the month of March in 2019. And they were to come out with it by October 2019. I don't know what happened. And then the COVID happened and everything just went off. That up till now, they've not come out, you know, because they called us for the launching of the this test. And that's how I know I had attended that program. But somehow it never came into the market.
Now the company is getting sold, so don't worry.
Looks that way. Something is happening. I don't know what. Yes. Madan, we can go ahead.
Thank you, all the chairpersons of session and the wonderful speaker, Dr. Sujata ma'am. Thank you. We will move on to the panel discussion, which is on management of severe hypertensive disorders of pregnancy and its complications. It is being moderated by our Dr. Sneha ma'am. And may I have the CVs of panelists? Yeah. Dr. Geeta Balsarkar ma'am, who is the Editor Emeritus Journal of OBGY and Secretary of Mumbai OBGY Society, President of Association of Medical Women of India, Mumbai branch, and President of Menopause Society of Mumbai branch in 2021. Welcome, Geeta ma'am. Yes, Dr. Payal Lakhani ma'am, who is the additional professor, SET GS Medical College and Nauroji Wadia Maternity Hospital. She is UG and PG MOHS recognized teacher too. She is attached to many hospitals. Welcome, ma'am. Dr. Niranjan Mayadev, who is the professor and head of the department, SET GS Medical College and KEM. And he has a lot of teaching experience and UG and PG teacher too.
Can I interrupt for a minute?
Yes, sir, please.
Yeah, I have retired. This is an old slide, so I have retired.
Okay.
So all these are oldie.
Yeah, okay, sir, it's okay. Next, Dr. Priya Vora, MOGS Managing Council member since 9 years, Youth Council mentor for 5 years, Secretary Mumbai Menopause Society, Secretary AMWI Mumbai branch. Welcome, Priya ma'am. Dr. Shailesh Kore, sir, Second Vice President of MOGS and past Secretary of MOGS. Welcome, sir. Dr. Rahul Mayekar, sir, is the Professor and Unit Head and Department of OBGY, LTMC and Sion Hospital. Welcome, sir. Dr. Ashok Anand, sir, past HOD, OBGY, Grant Medical College and JJ Group of Hospitals, Mumbai. Welcome, sir. Yeah, I welcome all the panelists and request Sneha ma'am to continue the session.
So a very good evening to all of you. At the outset, I would like to thank the entire team Amogs and of course the team Mumbai. Dr. Suvarna Majam, Dr. Geeta and Dr. Sujata have already thanked you during the inauguration itself. Without much ado, we would like to go ahead with the panel discussion. I can just say that this panel discussion is only to add to my knowledge also. I can see so many illustrious panelists here, which can add value to the discussion. And of course, I'm sure this is going to be even my presentation is going to be edited after this panel. I'm sure there will be a lot of additions to this PPT. So I would just start by the introduction saying that, all of you know that hypertension, hemorrhage, and sepsis, these are the three major killers of our women. In spite of, we just heard the talk by Madam Sujata, in spite of having so many predictive factors, right from the maternal characteristics and of course the various biophysical and biochemical tests, we are still not able to predict the hypertensive disorders of pregnancy, and we're not able to control or reduce on the maternal morbidity and mortality to that extent what we are expected to do. So definitely, we have to introspect and try to work on this. So I'm sure we have to really ask this question whether we really are taking the blood pressure ourselves, or we are depending on our assistant doctors or nurses. Are we using the proper size cuff? Are we using the proper measuring device, whether it's a mercury sphygmomanometer or the calibrated device or so? And I mean, are we really doing this in the patient who is physically and mentally relaxed, whose bladder is empty, has not consumed any drug, and so many other, ideal conditions. So definitely we have to focus on these aspects of prevention of not only the complications, but also this is the time to prevent even the preeclampsia, I would say. So I would start with the simple questions that what are the immediate complications of severe hypertensive disorders of pregnancy, because we are discussing only the complications today. What is the cutoff for blood pressure for this? I think we can start from Dr. Geeta, and I'm sure you will start with the discussion well, so that all the attendees will have very good take-home messages. So, Dr. Geeta.
If you are talking about the severe hypertensive disorders of pregnancy, anything more than 160/100 is taken as severe hypertensive disorder. And the immediate complication is that everything, like you have to remember that hypertensive disorder of pregnancy, though it is because of pregnancy, but it can affect many organs at the same time. If it can affect the kidney, there can be renal artery spasm, it can affect the kidney, it can affect retinal artery, there can be a cerebral bleed, there can be cerebral edema and convulsion. So it can manifest in many different ways. A complication can, or it can be a pulmonary edema, it can go any way. There is loss of fluid in the third space. So it is a complete multi-organ problem. It is not just the pregnancy itself. So the cutoff BP generally for severe HDP, I would take as 160/100.
Right. So as you have rightly said that, Doctor, I mean, previously the classification was mild, moderate, and severe, and now it has changed to severe and non-severe. So I totally agree with you that even 160/100 having the severity features of the alarming symptoms, signs, and the impaired laboratory parameters, we should take it as severe. So Dr. Niranjan Maidev, sir, I'm sure you all are teaching to your students all these things, but just for discussion, I would ask you that, why do we have to face all these complications when the blood pressure goes above 160, 110, and for how long, if it is there, the complications can result? Please discuss on this aspect.
Yeah, the basic pathophysiology here is because of vasoconstriction. And then, with vasoconstriction, if the circulation is affected, there's an extravascular edema which is there. And all these complications are because of extravascular edema, where, that extravascular edema doesn't come into the circulation. And so they remain for a long time, even after, correcting it. So the period of variability can vary anytime from 2 weeks, 3 weeks after if we deliver or remove the placenta.
Yes.
So that is one of the reasons why we should be treating this severe hypertensive pregnancies, so that we avoid all these complications, especially the renal and the CNS complications.
Right. Sir, actually what I wanted to ask you that whenever you have the, fluctuations in the blood pressure, to what extent, suppose if she has 160, 110 millimeter of mercury, so if that blood pressure remains for how much time, so that, the complications can happen, and before that we are supposed to control it? That is what the question.
If it is not controlled, not brought down to say 140/90, I don't want them to come down to completely normal blood pressure. But if it is brought down to a reasonable low level, then all these complications like 140/90, 130/90, then all these complications can be prevented. These are seen only if it is not treated for a prolonged time. Prolonged time can be, that she's not going to the doctor for 2 weeks, 3 weeks, hypertension is not monitored, and then she had all the features of these, accumulation of the fluid. That is the time when we see all these complications. So if she visits somebody and somebody detects this hypertension and treats it, maybe all these complications can be avoided at this point.
Right. So do we have Dr. Priya Ora? Dr. Priya?
No, I think she's not there. You can ask.
Right. Right. So, Dr. Payal, I would like to ask you that, we say that our vasculature is not adapted to such high blood pressure. So what is, once again, I ask you the same thing, that suddenly if we have the changes in blood pressure, within how much time the patient can convulse, or maybe, she can land up into all these complications?
So I think when we get this kind of high blood pressure, our treatment should be almost immediate, because anything more than 15 minutes is also enough for a patient to complicate severely. So that particular golden period has to be caught, and we really need to give her either IV labetalol and really get the BP down, like Dr. Maidev said, at least to 140/90, if not below that.
Right, right. So, of course, all of you know that, if it is not controlled, the first complication to happen is eclampsia. Your patient may convulse in front of you. And then, of course, comes the CNS complications and the respiratory failure, HELP, uteroplacental complications like abruptio, cardiovascular complications, and the renal injury, acute kidney injury, how Dr. Geeta just now talked about. So what are the alarming symptoms and signs that can warn you about this? Dr. Pyle, once again, I will ask you only. And then we go
anybody who suddenly has a rise of blood pressure of more than 160, 100, like Dr. Geeta said, with proteinuria added, along with, of course, when the patient gives history of headache or visual disturbances, she has edema feet, you do a urine protein analysis, and the protein urea is anything more than 2+, 3+, and that is when we know that, okay, now we are going to be dealing with a problem and we better act quickly. And then once we admit her and we send the lab investigations, and if we feel that the platelets are going into thrombocytopenia, we are going to have an SGOT-PT levels which are rising, and maybe that would evoke a suspicion of HELP syndrome, and that is when especially serum uric acid levels, LDH levels. So these are things that would really force us to act very quickly, and within 15 minutes at least try to get the blood pressure down, and of course consider an imminent delivery so that we can reverse the changes, of course, after stabilization of the patient.
Right. So we are mainly worried about the cerebrovascular and neurological complications. Of course, the uteroplacental complications are here to alarm us all the time. So we go ahead with this first case discussion. I'm sure this is a very famous case, which my presentation way back, I think 6-7 years, also had the same thing in near miss panel discussion, and Dr. Geeta herself has this case scenario in her presentation. We discussed this case that this is a 36-year-old lady who conceived on IUI. Her husband stays in Dubai and she stays in a village. So she comes to NC care for almost up to 28 weeks. The obstetrician conveys that yes, everything is fine, and then she's lost to follow-up. So one day she just reports to the PSC with pedal edema and severe epigastric pain at around 34 weeks. So blood pressure is, she has pedal edema and blood pressure is 178/116. So what is the diagnosis and what are the investigations we asked for this, and how do you manage this patient? Dr. Geeta. Do we have Dr. Geeta? I think she's not. I can see her logged in, but I think Maidev sir, can you take up this question?
Yeah, this is, pregnancy-induced hypertension of a severe variety. Probably she is not taking the tablets regularly at this particular juncture. And she has all symptoms. She has hypertension, edema, right, epigastric pain. And the most important thing which we are worried here is with all this, that she should not convulse. So at this particular juncture, it would be prudent to give her an antihypertensive to reduce her blood pressure, put her on Maxif prophylactically.
So sir, she was given only tablet nifedipine retard at this point of time. So how do you comment on this, sir? What drug should have been given for her?
Nifedipine is a good antihypertensive, but retard actually, the dose is erratic and we don't know what dose has been really given at that particular juncture. So if a proper dose is given and a proper monitoring is done, then
Right.
even Ipin could be a good alternative.
So what
Labetalol
antihypertensive you suggest for this
would
patient?
be a better option because it is
178 by 116, whether you want to give her oral labetalol or intravenous labetalol.
no, it would be wiser to give her intravenous at this particular juncture to control the blood pressure, and then subsequently decide whether to continue. And if the blood pressure comes back to normal, you want to continue the pregnancy at that particular juncture for symptoms revert. Or if they are not, after 6 or 8 hours, whether you would like to induce this patient and deliver. So that call has to be taken after 6 or 8 hours. And in the meantime, her blood pressure should be reduced. And given Maxelf will prevent her convulsions at a particular juncture.
Right. So, sir,
As
this
far as
patient was given tablet nifedipine retard. So, naturally, her blood pressure was not controlled. Her basic investigations were done there, what were available locally at the PHC. So, actually, this Priya, I can see Dr. Priya, and your question has come just now. So, this patient was referred to the higher center, that was sub-district hospital. She got admitted 2 days, almost 1.5 days later. So there they saw that tablet nifedipine retard is not working. So they just added tablet labetalol and they started with magnesium sulfate. Do we have Dr. Priya here?
Yes, ma'am.
Yes.
I've just done.
Yeah. So Priya, this is a case of severe hypertension, and I'll just tell you that she is patient who is 36-year-old patient who conceived on IUI. She was regularly coming for the antenatal checkup up to 28 weeks, where she asked the obstetrician, things are fine, and she's lost to follow. So at 34 weeks, she reported to the PHC because she stays in a village. So there the blood pressure was 178 by 116. So she was given tablet nifedipine retard and she was referred to higher center. So after 2 days when she reports to the higher center, here they saw that the blood pressure is not controlled. So they just added tablet labetalol and they started with magnesium sulfate. Okay. So what is the management of this patient at this point of time? 34 weeks, severe uncontrolled hypertension.
So, ma'am, all cases of uncontrolled should be in a high definition unit as it's rightly put. So she's having refractory hypertension, which is not responding to the treatment, and therefore sometimes we need combination.
Priya, I would interrupt you here. That she has received, see, 178 by 116, and she has received only tablet nifedipine retard. Let me know from your side that whether this is a severe hypertension.
This would be, I think, more in favor of severe hypertension.
178 by 116 without any thoughts.
We would like to even consider now, instead of the labetalol tablet, nowadays we have the intravenous therapy in this case.
Right.
So like we can give 20 milligram intravenous bolus and then 40 milligram after 10 minutes can be repeated, or combination therapies may help in these cases.
Right. So the only aim to stop here is before labeling this as refractory hypertension, we have to make sure whether she has received the proper appropriate antihypertensive in appropriate dosage. So she had not received that. Okay. For us, for severe hypertension, the choice was intravenous labetalol or oral capsule nifedipine, right? Not tablet nifedipine retard. So the drug which was given was not proper, and even tablet labetalol, that is also not. So she has not received the appropriate treatment. So at this point of time, we will not call her or label her as refractory hypertension. In fact, we will start her on IV labetalol.
Intravenous.
Yes. And then we will wait for the result. So as you said rightly, you start, how do you give the labetalol and how much?
So you have to give it as an IV bolus intravenously. 20 milligrams should be given, and then 40 milligram can be repeated after the 10 minutes, and you monitor the blood pressure and see how she's responding.
Yeah. So if she's not responding to it, you increase to 40 milligrams. Wait for another 10 minutes and you increase it to 80 milligram with maximum of 300 milligram. But if it is not responding beyond 80 milligram, it's a time to add the other antihypertensive, right? Okay, so now our patient is in hypertensive crisis. So how do you differentiate between the hypertensive emergency and urgency? Dr. I think Payal, you can take up this question.
So basically, we have to, as a first line of treatment, start with labetalol IV to 20 milligrams and repeat it, and maximum take it to 300 milligrams. If we really feel that despite all of this, and we have given her enough time, maybe 2 hours, and the blood pressure is still not settling down, that is the time when we have to consider another antihypertensive, maybe in terms of a hydrolysine or a nitroglycerin. Of course, I don't have too much experience with that, but then we have to consider these antihypertensives because we have to get down the blood pressure, or we are going to deal with end organ failures.
Right, right. So I can ask, I think, do we have Dr. Mayekar? Do we have any other panelists here? I can see somebody, new person joining. Hello? No. So Dr. Geeta, I think we will come back to you that when you have such severe hypertension, yes. So how do you differentiate between, I mean, when you think of managing such severe hypertension, what things do you consider whether you should take this pregnancy ahead or you have to terminate? So what are the points you consider in management for this patient?
The points to be considered in management are for the mother as well as the baby. Sometimes for the mother, if this hypertension is associated with severe edema, with severe knee jerks, which are very brisk, if she gives symptoms like epigastric pain, headache, blurring of vision, and or she throws a convulsion and becomes eclampsia, then we need to terminate the pregnancy. Or if for some reason the BP, even with full dose antihypertensive, it is not getting controlled, then we have to terminate the pregnancy. And for the baby, either severe IUGR, it is absent, there is oligohydramnios, then we may have to terminate pregnancy for the baby.
Right. So in other words, I would ask you whether your patient has got hypertensive crisis, but whether it is an emergency or urgency, how do you decide on this? Yes, Dr. Priya. I think Geeta, we are not able to hear you. Dr. Geeta. Can somebody take up this question? Yes, Priya. What is hypertensive emergency and what is urgency? Hello, can you all hear me?
Yes.
Yes. So, Payal, Dr. Payal, would you like to answer this?
Ma'am, urgency is when there would be no end organ failure.
Right.
And hypertensive emergency is when we are going to be suspecting an end organ failure, in which case, after stabilization of the patient, imminent delivery is mandatory, because otherwise, unless we do that, we are not going to have reversal of changes.
Right. So for hypertensive emergency is when you investigate this patient, and if you tell she has signs of end organ damage, then you have to bring down this blood pressure as early as possible, stabilize this woman, and think of plan for delivery. Hypertensive urgency is you have severe hypertension, but there's no end organ damage, and this patient you can stabilize, bring down the blood pressure over 24 hours, and then you can plan whether you can take this pregnancy ahead or go for termination. As you all of you know that
can I interrupt for a minute?
Yes, please.
Yeah, see, even for an emergency, if there is an abruptio, right, and if we don't terminate at that particular juncture, though there is no at the current moment there is no end organ affection, but these situations can really go bad and worst into DIC with causing end organ failure. So in such
fact,
situation,
eclampsia, abruptio, these are in fact the end organ damage. That is what we are saying. that if at all you have end organ damage, then you have to deliver, or rather plan for delivery as soon as possible.
Immediate.
Immediate, as soon as possible. So this is capsule nifedipine, what we were talking about. So naturally, those who are well versed with giving intravenous labetalol and comfortably can go ahead with IV labetalol. Those who have not used it, maybe do not have the help from physician, also can go ahead with capsule nifedipine 10 or 20 milligram as per the titration. Right. So do we have Dr. Ashok Anand with us, sir? If at all you are there, can we have some discussion from your side, sir?
I'm traveling, but I'm there.
Okay. If at all you feel comfortable, please do add value to our discussion, sir. That at this point of time, what is the role of magnesium sulfate? And from you, definitely, for the audience, I would ask you what is the difference between the prophylactic and therapeutic magnesium sulfate.
I just joined, of course, but then if you are thinking about role of a magnesium sulfate at 34 weeks with 170, 120 BP, if I'm not mistaken.
Right.
Then yes, it is very much indicated. One, it will prevent the eclampsia convulsions.
That is prophylactic.
Second thing is,
that is prophylactic. Yes.
Prophylactic magnesium sulfate. It will prevent the. It will prevent definitely convulsions.
Right.
Second thing is it will act as a neuroprotective.
Correct. Correct.
It will act as a neuroprotective on the baby.
Right.
So, and if you see the incidence of complications following a magnesium sulfate and without magnesium sulfate, you would find that all those complications are comparatively much more without magnesium sulfate rather than with magnesium sulfate.
Correct.
So I would certainly advise magnesium sulfate in those cases.
Sir, that is a very, very valuable discussion from your side. I would just make a request to you, sir, whether just for the house, that whether the therapeutic and prophylactic magnesium sulfate, how do they differ? Or it's only the words they differ and the dosage and the regime remain the same?
No, I think, see, for the therapeutic, we usually go beyond the delivery, 24 hours beyond the delivery or from the last convulsion. As far as the prophylactic dose is concerned, till the this one, the signs of prodromal symptoms are there. Once they are subsided, then you can stop the magnesium sulfate. That is what we are doing actually.
Okay, so Dr. Geeta, would you like to say something about this? Dr. Geeta? I could see her just now. Okay. So usually it is the therapeutic and the prophylactic magnesium sulfate, though the words differ, the dosage and the schedule remain the same. As you have also talked about it. Only thing is, when we continue to monitor this patient for 24 hours by the parameters we already know, and of course we continue it for 24 hours or as long as it is needed. I can see Dr. Geeta. Do you want to add anything to this discussion? Prophylactic and therapeutic.
Madam, what I want to say is, Indian women sometimes are thin-built. So even your prophylactics can act as therapeutic. There are a lot of papers on half-dose magnesium sulfate, which is used for neuroprotection in the mother. Hello?
Can we mute other people here? So it is said that, to the World Justice Organization, the therapeutic and prophylactic magnesium sulfate, as far as the dosage and the regime is concerned, it is absolute one and the same. It is not that only till the prodromal symptoms is there. That is what the message is. So definitely, Saiti. Okay, so already we have discussed that this is the magnesium sulfate, which is for prevention of eclampsia as well as for neuroprotection. And of course, by the time she's just 34 weeks, so you can give steroids also. We will not discuss what steroids. All of you know this well. So we just go ahead with the discussion that suppose this patient, now you feel that, you know, she is into hypertensive crisis and there is end organ damage. So once you stabilize her and you plan for delivery, so it's not favorable for vaginal delivery. So if you plan the cesarean section for this patient, Dr. Maidev, can we have what precautions we should take for this patient and what anesthesia we should use for this patient?
The precautions is you should have blood components ready because there is a possibility if the blood pressure is high, she is likely to bleed at that particular juncture.
Yes.
And as far as anesthesia is concerned, I think we should leave it to the anesthetist.
Right.
Normally, in general anesthesia, I would not recommend regional anesthesia for them, but I think they are the best persons at that particular juncture.
Right.
At the same time, you should also be prepared for a hemorrhage on the table at that particular juncture, which is quite common, you know. Especially if the woman is given Maxelf, quite often, you know, we have seen that some of them bleed a little more than as compared to the normal patients if a Maxelf is given.
Right.
Plus,
What
neonatal
oxytocin you want to give for this patient? I would rather ask you that what about the preload, if at all, you know, the anesthetist says we are going ahead with regional anesthesia. So we obstetricians are the one who preload the patient. So any comment about any precaution on the preload you want to give because this patient?
No, the IV fluids should be given very slowly till, you know, you are going to deliver this woman. Post-delivery also, I think we should be little conservative of giving a lot of fluids at this particular juncture.
Restriction, right.
At the same time, you know, if possible, there should be a good neonatology team available during the section for these particular women.
And sir, any comment on the oxytocin? What you prefer for this?
I would first prefer always pitocin post-delivery for uterus to contract.
Okay.
If at all pitocin doesn't act, then you can use other measures like you know, methogen if required if she's bleeding torrentially. But quite often, you know, pitocin in a little larger
we give the message that we should avoid methogen as far as
in the larger concentration. Pitocin normally works.
Concentrated.
Rarely we have to use methogen.
Okay. Anybody differs on this whether you should use carbetocin as a prophylaxis?
Carbetocin can be used prophylactically. In fact, it is FDA approved for prophylaxis of postpartum hemorrhage. And it is nothing but a long-acting pitocin. So it works on the oxytocin receptors only. Therefore, instead of giving a lot of fluids and pitocin, we have to add in a pint. You can't give pitocin as a bolus. Carbetocin can be given as a bolus if these people fluid is like, you know, likely to go into pulmonary edema, but carbetocin can be safely used in these patients.
So I would like to agree with you and also share my experience that over last 3 years now, we are using carbetocin as a prophylaxis for all the patients. Especially, this is a patient for whom it is a very apt drug because, you know, you don't want overload. You have to restrict the fluids. And carbetocin acts quickly and it maintains the effect for almost 8 to 16 hours. It is equivalent to 16 hours of infusion of oxytocin. But once you give oxytocin, as it belongs, this belongs to the same family, when the receptors get depleted, oxytocin doesn't work and the receptors get depleted, carbetocin doesn't work. So if at all you have to give it as a prophylaxis. So that is what is the message. And of course,
I would rather say ki if you want to give carbetocin, if you are prepared, then give carbetocin first rather than oxytocin drip.
That is what I'm saying. That you give as a prophylaxis. Never give that when pitocin is not active.
Not working.
Not working. So when oxytocin, so give carbetocin as a first line therapy. And then, of course, if that doesn't work or you need some more, then of course you have the methergine and then carboprost and misoprostol tablets, all other drugs, but not this oxytocin. So oxytocin infusion you can of course continue in addition to carbetocin, but not vice versa. So that is what is the message. And of course, any precaution during third stage, if at all, this patient is having such severe hypertension, you have to be cautious about the fluid overload. You have to be cautious even for the third stage, that's the very reason you're not supposed to give methergine also, because that she can go into cardiac failure or even pulmonary edema. So any diuretics at this point of time would you like to give? After the delivery of the baby. After the delivery of the baby. After the delivery of the baby. Yes.
The basic problem in preeclampsia is there is restricted intravascular volume, and giving diuretics will further reduce the intravascular volume.
Yes.
And will cause a lot of fluid loss. So it is not preferable to give diuretic, but I would leave it to the anesthetist or the physician to take a call. If the urine output is really good, then I don't think there is any need to give diuretics to this patient.
If it is,
because it will further reduce our intravascular.
You're right in a way, but if we talk about the loop diuretics, it pulls the fluid from extravascular compartment into the intravascular compartment, and then at the loop level there is a diuresis. That is what is the mechanism for furosemide. So it is preferred usually during third stage of labor after you deliver the baby. In fact, that is one of the preventive measures for reducing the incidence of pulmonary edema. That is what is discussed. And now for this patient, we were talking about cesarean section. So they did the cesarean section, 1.9 kg female child was delivered. And in spite of all this, because the antihypertensives were not appropriate, and even appropriate dosage were not used, so blood pressure still remained inside within that range only. So almost 24 hours after the cesarean section, this patient, suddenly worsened, started becoming breathless, restless, and severe cough. She's had tachycardia, blood pressure 200 by 118, oxygen saturation falling down to 75%. So how will you manage this patient? I think we don't have Dr. Rahul Mayekar here, but anybody can take up this. I think Dr. Priya, we can hear from you. Dr. Priya? No? Anybody, I would say.
Two things you have to keep in mind. One is that pulmonary edema, because which is in the postnatal period within 24 hours. So we have to keep pulmonary edema in mind. Second is I would even think of cardiomyopathy, because that also sometimes presents similarly with these particular findings. So these are my differential diagnosis. So this patient definitely needs care in an ICU and should be shifted into an ICU. And maybe intubated, because oxygen saturation is 55% with oxygen.
Correct. So you are right, absolutely right. So this patient, she was made propped up, 100% oxygenation was given, IV labetalol and, furosemide 40 mg was given. But by the time they called for help and, she was worsening rapidly. And, by the time the anesthetist also reached, she developed cardiac arrest. And then she, of course, the mechanical CPR, mechanical ventilation, then she was shifted to ICU. She was managed by all possible ways. And then, of course, she was stabilized. And then she was investigated, ECG, X-ray, bedside 2D, echo, everything was then done, including ABG. This patient then could be revived after 1 hour. She was on spontaneous respiration and BP was 100 by 60. So we could revive this patient. But to introspect ourselves for this patient, high-risk patient, what has gone wrong right from the beginning? This high-risk lady coming to you for regular antenatal checkup. Have we really missed something? Could we have prevented this? Dr. Payal, we would hear from you.
Yes, definitely. This is a patient in whom hypertension has clearly been missed. And even when diagnosed, maybe she has not been
I would just
adequately.
interrupt you, Dr. Payal. I would just interrupt you. Sorry, because I expect you to predict right from early pregnancy. So, can we predict for this patient that she can develop hypertensive disorder, as we just heard the talk also?
Yeah, so if we have to go, you have to, as they mentioned about the gestosis score, we go into the history, we find out what are the high risk factors according to the history. Then, as a routine, when we do the first trimester screen and we do a dual marker, we get a PAPE report in that. So, if we see the PAPE is also reduced, then automatically we will suspect that this is a patient who is going to land up with hypertensive disorder in pregnancy. Also, when we do an NT scan, we always have the PI, uterine PI, which is measured. And if at all that is increased, then that is the time when I would start ecosprin on this patient, give her 150 milligrams of ecosprin regularly. And one thing that I personally believe is that whenever we do suspect that this is a patient who is at a high risk for developing hypertension, now one very good thing that has happened is post-COVID, the prices of that home BP monitors have gone down. So I generally request my patient that please buy one and do a home BP monitoring, so that even between two antenatal visits, if there is a blood pressure rise, you can pick it up, and we have to educate the patient that at all she has a BP of more than 140/90, she has to come back to the clinic so we can aggressively manage it.
Perfect. As I've already shown right in the beginning, that even a calibrated digital BP monitor is definitely a useful tool for home monitoring. Only one thing I want to add: when you have the HDP gestosis score as a high risk, that is 3+, then definitely you should start her on aspirin, low dose aspirin, and high dose calcium. Nowadays, the recommendation is 1.5 to 2 gram of calcium. Okay. So thank you so much, all of you, adding so much to this discussion. So we go ahead with the second case now, I think, and we'll discuss only one case, and I think we conclude. We have this 31-year fourth gravida para 1, 2 spontaneous abortions previously. Now 34 weeks of gestation. She's seen in the antenatal clinic complaining of vomiting. Her blood pressure measured in the OPD is 130/90, no proteinuria. Hemoglobin is 8.5, platelet count 70,000, SGOT, SGPT elevated 60 and 76, and LDH is more than 600. Okay, so what is the probable diagnosis from this scenario, and how will you manage this case? Anybody I can request.
Looks like Mogs syndrome, because the liver function is altered and the platelets are reduced. So it to be like she is in syndrome. Since she is 34 weeks, within a small period of time, her BP will start rising. The one which is 130/90 will also start rising. Low hemoglobin, actually, even in hemoconcentration, if she has 8.5 gram hemoglobin, maybe even lesser than this. So probably she is in HELP syndrome and she needs the termination of pregnancy.
Right. So for HELP syndrome, it is absolutely no continuation of this pregnancy. It is mandatorily delivery. Of course, you have to make all the arrangements for the fetus, for the mother, right? So what all management or what all arrangements you want to do? Priya, do you want to take up these questions? Please go ahead.
Yes.
Yeah.
So the most important in health, we have to deliver the patient. We need to keep in mind that there could be a coagulopathy which is associated. So these patients need to be managed at a higher center. We need to first stabilize. So if she's not, you need to stabilize the mother. You need to check the fetal condition also. In these cases, if there's a consumptive coagulopathy, then of course, yes, you need to treat this. And then you have to deliver. So it's better that she's in a tertiary center for delivery. And for the baby also, if it's less than 34, you need to give Maxal for the neuro protection also. And steroids, if they're under 34 weeks, then we would need to consider the steroid administration and deliver these patients at the earliest.
Okay. So, this patient is in frank HELP syndrome. You can make out here very clearly the liver enzymes are elevated, platelet count going down, and hemoglobin is 8.5. Though the serum bilirubin is not mentioned or the PS findings are not given, most probably she's landing up into hemolysis and hemolytic anemia. That is what is from this case. So definitely, as you said, you have to deliver this woman. Any role of conservation? Absolutely no, that you have already talked about. But then when you want to deliver such patient, do you have any role of steroids for HELP? Any therapeutic role of steroids for HELP syndrome? And if at all, what is that?
I'm not sure, but I think, ma'am, plasmapheresis or there is some therapeutic where you can give for HELP. I'm not sure of the dosage, but it can be given.
Okay, so Dr. Payal?
Ma'am, steroid cover over here would only be important for maybe 24 hours if she has to be shifted from a smaller institute into a tertiary institute where for a short period of time it will stabilize the platelet count and prevent a further drop in the platelet count. But waiting anything beyond 24 hours is absolutely not advisable.
Right. So basically, we are not sure about its therapeutic role. That is very, very clear. But yes, there is no harm in giving. And of course, it is said that 10 milligram, 3 times, almost 30 milligram of it gives you only the window of 24 hours where it halts the further damage, where, worsens, it prevents the further lowering of the platelet count when you are planning for the operative delivery. And that's the only advantage you can take up. You are utilizing this window of opportunity. Otherwise, there is absolutely no role for the steroids, as a therapeutic measure. So definitely for this patient, it's only that you have to repeatedly do the investigation, see that she is not worsening, the platelet count is not going down. On one side, you are giving Maxelf and steroids for the baby, and on the other side, you're making all the arrangements for blood and blood component, and you take this patient for cesarean section or operative delivery, whatever. I think that's the only thing for HELP syndrome. There is absolutely no for prolongation of the pregnancy. Dr. Maidev, sir, do you want to add something to this?
See, I would rather prefer to induce this patient and deliver normally with blood fractionation rather than,
Yeah, that is what we said. We try to terminate this pregnancy. If favorable, we go for induction. But if at all it is not favorable, because 34 weeks only. So if it is not favorable, then we go ahead with the operative delivery.
And then, most important is keep platelets and blood components ready so that, all these complications of hemorrhage, liver, subcapsular, everything can be really prevented. And that should be the main aspect rather than, delay. So as you literally said, steroids, we are just buying time probably to get all these platelets and everything.
That is what we say. By
really
the time,
no role.
yes, by the time you keep, prepare the fetus and mother, that's all. Otherwise, yes.
I want to add that once the diagnosis of HELP syndrome is made, that the patient should be delivered is a no-brainer. We all know this. The main problem occurs in diagnosing. We tend to drag our feet, and patients somehow in India, they are not ready to get delivered in the 8th month. So they will request you to give them time, 48 hours, this, that. So we sometimes tend to drag the diagnosis, and this exactly can be very lethal for the patient.
Right. Absolutely. Absolutely. In fact, once you diagnose it, I think we have to conceal them. As you said rightly, that we have to bombard on them, that if at all, it is not terminated, the more you wait, more damage will be done both to the mother and to the fetus. So that is what the message very clearly given, Dr. Geeta. Thank you so much. And ultimate management is delivery. That is what But even post delivery, you don't have to relax, because health may not stop progressing. All of you know that even 10 to 15% of these health syndrome, they're without hypertension, without proteinuria. I'm sure all of you know this also. So you have to be very cautious even after delivery. You have to continuously follow this patient, even with the repeated evaluation of all these investigations, and continue to see that she's stabilized before discharge. I think that is what the message is. So I think, should we stop here, Dr. Geeta?
Yeah, I think it's already 8 o'clock. I think we should stop.
That is what I'm saying. In fact, I had said that only 2 cases we will discuss, because both the cases are very interesting. So I'm very thankful to team Emogs, especially Madam Suvarna Kadilkar, Dr. Geeta, and of course, Madam Sujata Darvi. I'm thankful to all the senior, respected seniors, and all the past presidents who graced the program, blessed us. And of course, I'm thankful to all the learned panelists who added value to this discussion. And I take this opportunity to thank everybody to be with us and to get collaboration of this program. And once again, I just utilize this opportunity to make a humble appeal to all of you, rather, to support my candidature as Foxy Vice President from West Zone. I would really be, obliged to have your support, and with your help, I want to go ahead as Foxy Vice President. I hope I can do justice to this post. And the voting is starting from 1st of August. It is only day after tomorrow. So once again, I request all of you. Thank you so much.
Thank you, Sneha, and the team, and best wishes for your Foxy endeavor.
Thank you so much, madam. Thank you so much.
We are with you, madam. Don't worry.
Thank you, sir. Thank you, Dr. Payal, Dr. Niranjan, sir. Thank you, Dr. Anand.
Ashok is also there. Ashok Anand is also there.
All the best. I'm traveling in between the notes.
I know. But it was really great to have you, sir, and your valuable inputs. Dr. Priya, thank you so
Priya
much.
is also.
Thank you, Dr. Geeta. Once again.
Thank you, Sujata.
Yes.
Thanks.
Thank you, Sujata.
Thank you, everyone.
Thank you, ma'am, and all the best.
My special thanks to Madam Sujata Darvi for convening this program so wonderfully. And thanks to both the coordinators, Dr. Monica Umbadan and Dr. Matan Kamre, for helping me reaching to all of you. Thank you so much.
Thank you. Chalo, bye. Bye.
Thank you.
Bye, Madan. Thank
you,
night.
Amogs, and thank you, Emogs, for associating with Emergency Obstetrics Committee. Thank you, all Amogs office bearers and Emogs office bearers. Thank you. Thank you, all the speakers, and thank you, all the chairpersons, too. Yeah.
Thank you.
Bye. Good night. Good night.
Good night.